let's talk about special populations. And some of this lecture is going to really apply more so to the APRN role of things rather than the anesthetist role of things. But these are all things that we need to be aware of, that we need to understand. And certainly, whenever we're in like the pre-op clinic or we're dealing with patients who belong to special populations, I'm talking pediatrics, neonates, older adults, geriatrics, we need to be able to understand and relate to them. So let's talk initially about infancy through adolescence. Now, whenever you think about the principles of childhood development should proceed along a very predictable pathway. There are milestones that children should reach. Walking by approximately 1 year of age is a great example of a milestone. There's a range of normal developments. Now, granted, this range is wide, okay? There are children who, at 3 years of age, are able to start reading. There are children who do not speak until they're 3 or 4 years of age. There are various physical, social, and environmental factors, as well as diseases, that can affect childhood development and health. If you think about the bell curve, bringing things back from your statistics course, okay, we know that most people fall within 2 standard deviations of the bell curve. There will be outliers on the far right and the far left. Those of the far left will have some developmental delays, and those of the far right will meet and reach their milestones much sooner. And environmental factors, so how someone's family life is, how someone's social life is, can affect a child's development and health. And then these developmental levels affect how you conduct the history and physical exam. Okay? So what I mean by that is when you have a very cooperative 4 or 5-year-old, you can probably ask them, have you had anything to eat today? And they'll tell you very honestly. You may have a child who is 7 or 8 that is nonverbal or speaks very minimal, that you may not be able to get that information out of. I'll never forget one of the most cooperative young children had a heart murmur. One of the most cooperative young children I've ever worked with had a heart murmur, and I was able to take the ultrasound and go over there and do a point-of-care scan, and this kid was absolutely fascinated, okay, by the ultrasound probe, looking at the screen. All right, I was able to sit, I could have probably ultrasounded him for 30 minutes. He was incredibly cooperative versus other kids. You have them assess their Mallampati score, assess their airway, and they're really not going to cooperate with you. So those phases of childhood development are important for us to recognize. They're important for us to be familiar with. And when something is outside of the norm, that should immediately alert us to ask more questions, to further assess things. So when it comes to the surveillance of development, we oftentimes will look at physical, cognitive, language, social, and emotional features. So thinking about physical features, are they appropriately sized? Do they appear their stated age? Is this a child who, at 5 years of age, is only 18 pounds, 20 pounds? That's certainly abnormal. Or is this a child who is 2 years of age that is 50 pounds? Where do they fall within their percentile for age and weight and height on a growth chart? What is their cognitive developmental state? Are they able to communicate appropriately for what would be a quote-unquote, I don't want to say normal, and a child of average age? How's their language? Are they able to communicate with you? Are they able to not only understand cognitively, but are they able to verbalize things back? Can you understand them? And how are they when it comes to social and emotional development? Are they playing? Are they interactive with others? Are they able to make eye contact and hold eye contact? Is that socially acceptable in their culture? That's another question, because there's also a cultural component of this. But are we able to take them away from their mom and dad to the operating room? are they going to be somewhat cooperative? Can they be away from their caregivers for a short period of time? Because there is an age where that child is, no matter what, is probably going to be very upset. But by the time they are 6, 7, 8 years of age, they should be able to at least somewhat cooperate as we head back to the OR. They may still get upset before you mask them down, but if they're completely losing it, they probably have not met their social and emotional milestones. Now, when you think about key components of pediatric health promotion, there are some things. First, let's talk about the age-appropriate developmental achievements of the child. We were talking about physical growth and development. Have they matured? Are they on track for where they should be? If they are adolescent, have they reached puberty? What are some obvious signs that are telling of this? How tall are they? What is their motor, gross and fine motor developmental skills? Are they able to write? Are they able to draw? If you have an 18-month-old that cannot balance themselves standing up, that is a motor delay. What about their cognitive developmental milestones? Think about language and school performance. I'll never forget, this is probably, a year ago. I was taking care of a little child. I think he was 7. But mom told me he was in 3rd grade, and I thought, that doesn't sound right. And I said, he's in 3rd grade? And the kid spoke up. He said, yes, I'm in 3rd grade. I skipped 2 grades. Oh, okay. And so what had happened is, I think he had technically only skipped 1, but he was incredibly intelligent and quickly did not stay in kindergarten, went to 1st grade, and then they moved him ahead. He was already doing multiplication and division, and I'm like, what are you learning? He's like, well, my class is learning their times tables, but I already know mine. Oh, really? Start asking him, and he proceeds to tell me his times tables. There are certainly people who are going to cognitively develop much quicker, and they're going to do better in school and performance, but they may not emotionally develop. How's their self-regulation, their mood, their self-esteem, their independence? Are they sociable? Those are things that we can observe. And then this also goes into looking at family dynamics a little closer. How are they with their family and their caregivers? There's also health supervision visits. Children should be assessed at their physical, developmental, social-emotional, and oral health milestones. Children who have special needs, who may not be meeting milestones, will need more frequent visits. And then oftentimes we can integrate components of the physical examination with health promotion, not only teaching, but also ensuring that the child and the caregiver or parent is comfortable. This can bring up some sometimes controversial topics like immunizations, screenings, and at times oral health. Look at the parents. Look at who the child is with. If they're with someone who does not have good oral hygiene, do you think they're adequately teaching that child to brush their teeth? Do you think that they're eating a diet full of healthy vegetables? Probably not. So these are times that we can integrate health promotion in our screenings. Now, looking at guidance that can be provided, not only healthy habits, nutrition, healthy eating, safety, prevention of injury, physical activity, sexual development and sexuality, self-responsibility, efficacy, healthy self-esteem, looking at positive family relationships, parenting strategies, how reading aloud with a child is so important, the child's emotional and mental health, their oral health, recognition of illness, sleeping schedules, screen time, prevention of risky behaviors, school, vocation, peer relationships, community interactions, and then partnerships among healthcare providers and the community with children, adolescents, and family. These are all serious components of pediatric health promotion, and this really can span the entire from neonate to adolescent period. Now, when it comes to obtaining the health history on a newborn, What are their parental concerns? Oftentimes, if we're seeing a newborn as an anesthesia provider, we're seeing them either because they're having a procedure done in the hospital or they are coming back for a procedure. We want to have a good prenatal history. What is that child's PCA, their post-conceptual age? Were they premature? Are they meeting developmental milestones? What has been their neonatal course? Did they spend 3 months in the NICU and now 1 month later they're presenting for surgery? What is the cultural, family, and social dynamics? What do you see before you? Are there things that are alarming or maybe things that raise cause for concern during the visit or assessment? How's the child eating? Are they sleeping? What about their stool? What about their urination? These are all things that are important to ask. And then, of course, safety and anticipatory guidance. Oftentimes, we're guiding families, we're guiding parents on how to properly care for their children. One thing when it comes to feeding and nutrition, parents who do not have the appropriate education or may have not been taught themselves, they may not understand why it's important to not give a child Mountain Dew. They may not understand why it's important to keep a child on formula, or when to properly transition to adult food, why it's not ideal to give a child pure, straight juice, why it should be probably watered down at first. These are things that we can teach not only as anesthesia providers, but really relying on certainly our foundation. We're nurses. From the very beginning, we can help teach and educate people on how to properly care for children. So now let's talk about some developmental milestones in that first year of life. There are gross motor, fine motor, language, and social emotional. These are important to know for assessment. Gross motor, at 1 month of age, the child should lift their chin up in the prone position. They should be able to turn their heads up when prone. They're able to fist their hands. They can start to make some subtle sounds. And there's also a discriminate recognition of the parent's voice. Maybe they can follow the face. At about 4 months of age, they should be able to sit with some support. Their head should not lag. It should roll from front to back. The hands are normally predominantly open at this age. That fine motor movement is developing. They're reaching for objects. When it comes to language, they're able to laugh out loud. They will stop crying to a soothing voice. And oftentimes, kids will display a very social smile. Now, at 6 to 7 months of age, they can start to sit propped up on hands. They have some lateral protection. They're bouncing when held. They can transfer objects from hand to hand. They can reach out with one hand. They could begin to feed themselves something small like a cracker. They will babble. They're making constant sounds. And they begin to understand words like no. They can enjoy seeing a reflection in the mirror. Looks from object to parent and back when wanting help. By 9 months of age, they're pulling themselves to stand. Bear walking. They begin kind of creeping around. Pincher grasping. They can bang 2 cubes together. They're now saying mama, not non-specifically, and will imitate sounds. They're now oriented somewhat to name. They can follow a point. They enjoy games like peekaboo. And they begin to develop a little bit of that stranger, that apprehension, that anxiety. By 1 year of age, they're standing independently. They're beginning to take their first steps. Maybe they're scribbling. They're holding a crayon, beginning to stack blocks to make towers. They can say one word with meaning. Mom, dad, mama, dada. Pointing to objects. Follows one-step commands with gestures. And then can display and show objects to parents to share. These are the important to know developmental milestones from birth to 1 year of age. Now, the techniques for examination in children. One of the first things we learn are the APGAR score. Now, ironically, the APGAR score was developed by a female anesthesiologist to help to grade or score infants. We should be able to understand gestational age, post-conceptual age, and then recognize normal growth. What is normal length? What is normal weight? Head size. And of course, you have to be able to recognize normal vital signs in children, in neonates, in infants. You have to know this. You are an anesthesia provider. You're going to care for children across, from infancy, across their lifespan to geriatric. When you're thinking about assessing skin issues in young children, oftentimes we're looking for acrocyanosis, jaundice. How do their eyes look? Assess those closely. Myla, miliaria rubra, erythema toxicum. Look for those transient neonatal pustular melanosis spots. Maybe eyelid or salmon patches. Café au lait and dermal melanocytosis are also prominent skin issues. Ask questions. Has their skin always looked like this? Has it changed recently? Does anything make it better? Does anything make it worse? Those are questions you need to ask and assess, because if you're about to take a child from a parent for a procedure, you need to annotate normal and abnormal findings. That's incredibly, incredibly important. Looking at their head and face, look at the cranial sutures and the fontanelles. Assess the circumference and symmetry of the head and the face. Chavoskic sign, tapping on the face. Looking at their sight and hearing. Are they able to track? Are they following you? Inspect their nose. Feel their sinuses. Look in their mouth and their pharynx. These are all important things to assess. Now, will you be able to adequately assess a child's Mallampati score? Certainly not. It's hard to get them to cooperate. But with a tongue blade, you should be able to inspect these things. How's their sight and hearing? Are they tracking you? Do they appear glazed over? Are they following? These are things that are important to not only assess, but to recognize if they're abnormal when caring for children, when caring for infants. Recognizing some abnormalities in children is important. Upslanting may be associated with Downs. Downslanting could be associated with Noonan. Short could be related to fetal alcohol syndrome. These are all things that we need to be able to recognize. And then what goes along with assessing somebody with maybe Down syndrome? Atlanto-occipital instability, cardiac problems, conduction abnormalities, Noonan syndrome, difficult intubation, and that kind of goes along with Down syndrome and fetal alcohol syndrome as well. With fetal alcohol syndrome, who's caring for that child? Who's their caregiver? How's their feeding? How's their eating? What's their development like? These are all important things that we should be assessing. Now, when it comes to assessment, how do you do this? Start with your inspection, what you can see visually, and then focus then on the body systems. Listen to their lungs and their heart. Pay close attention. Assessing their heart, their chest, their breast, their abdomen, their genitalia. Now, some of these things we're not going to be assessing necessarily as anesthesia providers, especially genitalia, the breast, but you need to be able to recognize signs and assessment that are not normal and not appropriate. Bruising. Look for musculoskeletal, nervous system changes. How is that child responding? These are things that you need to be aware of. And this really goes hand in hand with foundational nursing knowledge. but really builds as an advanced practice provider. We need to protect children, protect infants. And what does that mean? That means that we, as healthcare providers, need to recognize abnormalities and step in. We need to report things that are not normal. Make sure we are charting effectively and safely. What about those primitive reflexes? Palmar and plantar reflexes are important to assess. Are they rooting around? Do they have a Moro reflex? Gallant, Landau. Parachute reflexes, positive support, placing and stepping. These are all reflexes that are important to assess and be aware of. And why is that? Because at certain stages, at certain milestones, there's a change in these quote-unquote primitive reflexes. Now, if a child at a certain age still has a primitive reflex and has not grown or developed more, that becomes alarming. That needs to be charted. Do the parents know that something is not quite right? Are they in denial when asked about these things? There's certainly a difference in someone being a late bloomer and having a Babinski reflex at 2 years of age. Okay? Sometimes we have to have uncomfortable conversations in assessment, and that's okay. That's just fine. You have to become comfortable having those uncomfortable conversations. So now, what are some things we can do for health promotion and counseling? Well, number one, you should plot a development chart, an infant schedule. What should parents be expecting from birth? 3 to 5 days, 1 week of life, by 1 month, 2 months, 4, 6, 9, 12. Some of the things we have just discussed. But parents should be aware of this. They should have goals in mind. And they're the ones who are spending the most time with a child. They should be able to recognize when something is abnormal. Building family rapport. What should they anticipate? What guidance do they need? Who can they go to for help? These are important things to discuss. And why is that important? Because people need resources. Not everybody has a healthcare provider's background. Not everybody can understand the importance of these things. That's why it is so crucial that we as healthcare providers are able to provide health promotion and counseling to families. Now, in early childhood development, what are some things that should be happening? What are some of the normal things? Collaboration with family. How does that child interact with other members of the house? Are they reaching their physical, cognitive, language, social and emotional milestones? How do they interact with children, other children? Are they using aids? These are important things to assess. Oftentimes, we will observe them, maybe putting them in an area where there are toys, where there are things that they can grasp, things that can catch their attention. While we're able to talk to the parent, we're now able to visually assess how that child interacts. Is the family apprehensive about putting them down? Is that child getting the cognitive stimulation they needed? Are they getting that physical stimulation? How do they interact? Do they have toys? Do they have aids? Have they been visually stimulated? These are important things for us to assess and understand. Some more developmental milestones from 1 year of age to 5. And we've talked about that 1 year of age. Standing independently, starting to take those first steps, scribbling, holding a crayon, stacking blocks to make a small tower, saying one word repeated with meaning, pointing, following one-step commands with gestures, showing and displaying objects to parents to share. By about 15 months of age, are they able to stoop down and pick up a toy? Are they able to climb up on furniture? They're still going to be running stiff-legged. Are they using a spoon with some spilling? Can they place some cubes in a cup? Are they able to turn the pages in a book? Are they using a few words? Their speech jargon should be maturing. They can point to a body part. They could show empathy, give hugs on request by about 1.5 years of age. They should be able to creep down the stairs. They're running well, stacking 4-cube tower blocks, vertical. They're able to use approximately 10 to 25 words. Able to identify body parts. Show me your hand, show me your feet. Points to themselves. Show me your mom, show me your dad. And they're able to start to begin engaging in pretend play. By 2 years of age, 24 months, they should be able to walk downstairs holding onto a rail. Normally with both feet on one step. They're able to kick a ball. They can imitate a horizontal line. They can begin to open a doorknob. They can suck through a straw using a straw. They begin to use 2-word sentences. Mama, help. They'll have about a 50-plus word vocabulary. They can refer to themselves by name. And they practice that social and emotional. They practice what's called parallel play. If you notice, they might be in a group of children, but they're really not playing together. By about 2.5 years of age, 30 months, they're walking upstairs, holding on, alternating their feet, jumping in place. They can stack a tower with 8 cubes. They can wash their hands and brush their teeth with help. They should be doing this. This should help them in life. They can refer to self with their correct pronoun, understand action words, not only sleeping, eating, playing, prepositions up, down, around. They can imitate adult actions, cooking, talking on the phone, cleaning. By 3 years of age, they're going upstairs without holding on, alternating feet. They can pedal a tricycle. They can copy a circle, start to draw, string small beads together, so fine motor skills. Draw a 2 to 3 part person. They're not going to be Rembrandt here, but they're learning. They can have 3-word sentences. Their intelligibility is about 75%. They can understand negatives, no. They know and recognize one's own gender. They can begin to share, practice imaginative play, and they begin to fear some imaginary things. By 4 years of age, they can balance on one foot for about 8 seconds. They can throw a ball overhanded. They can catch a bounced ball. They can copy a square. They should be able to use the potty alone. Drawing a more complex person, 4 to 6 parts. Their speech should be about at 100% intelligibility. You should understand what they're saying. They should follow 3-step commands and understand adjectives, descriptions. They have a preferred friend. They can label their feelings and practice group play. And by the time they start school at 5 years of age, walking downstairs with alternating feet, they can hop on one foot, skip. They can copy a triangle, cut with scissors. They can write their first name. Speak in 6 to 8 word sentences, count to 10. They would know their colors, telephone numbers. They can retell a story with a clear beginning, middle, and end. Enjoys rhyming words. Maybe has a group of friends. Apologizes for mistakes. These are all developmental milestones at that 1 to 5 year of age range. Now, when it comes to the developmental tasks of middle childhood, there are physical characteristics, cognitive and social. They should have enhanced strength and coordination. They should have a competence in various tasks and activities. You should be able to screen for strengths, assess problems, involve parents, provide support for any disabilities or additional needs. You should anticipate guidance, help them navigate safety, help them understand exercise, nutrition, sleep. Now, the cognitive developmental, concrete, operational, focused to be on the present, achievement of knowledge and skills, self-efficacy. They should have an emphasis on short-term consequences, support, screening for skills, and school performance as well. Social, achieving a good fit with their family and friends in school. They should have a sustained self-esteem and an ever-evolving self-identity. Assessment, support, advice on interactions, including peer relationships. An emphasis on their strengths. Understanding advice, understanding support, being able to comprehend social cues. Childhood assessment is very important. We should be able to get their height, their weight, know their BMI, check their vital signs, assess their skin, their head, their eyes, their ears, their nose, their sinuses, look in their mouth, their pharynx, inspect their neck, their thorax, their lungs, their heart, their abdomen, genitalia, musculoskeletal system, nervous system. These are all things that are important to assess. Now, from the anesthesia provider's perspective, okay, we're not doing in deep sexual assessment, okay, but we are going to recognize height and weight, their BMI, their vital signs, doing a good visual inspection, especially of the mouth, of their skin. Inspect their musculoskeletal system, their nervous system. At a certain age, nerve blocks should become something that we should consider. Well, not only knowing their weight, but their age can be very telling. Is this a child who is athletic and plays sports? Maybe avoiding a nerve block is the best thing to do. The second area of health promotion and counseling, this should very much be a discussion. It should be a conversation, a discussion with parents, focused on that developmental assessment and your physical examination. You should be actively screening them. Are they getting their immunizations? Providing education is one thing, arguing is another. Provide anticipatory guidance. Is that child soon going to be going through puberty? Are they reaching the age where they're going from elementary to middle school? Help them to form healthy habits, behaviors, family, community interactions, encouraging them to be social, participation in sports, activities, pursuing their own interests. That can be very telling, asking a child, what they like to do, what's their favorite thing to do, who do they like to hang out with, where do they like to go. These are very important and critical things that will be very telling and eye-opening. Now for adolescence, there's an acronym we use called HEDS, HEDSS. And that's where we ask about home, their education, or maybe their employment, activity, drugs, sexuality. These are important things to assess for. Suicide, safety, any physical, cognitive, social, and emotional developmental tasks that they're not reaching. In this day and age, sexual identity is very important, gender identity. Sometimes we have to provide information on high-risk behaviors, asking very direct questions, especially whenever a child is away from perhaps their parent or guardian. If there's something alarming that we expect, it's okay to have that frank conversation to ask them if they're safe, if they're self-harming, or if they have any other questions that we need to answer. Maybe children don't want to admit to risk-taking behaviors or drug use in front of parents, but the moment they leave, they tell you, oh, by the way, I do X things. These are important to know. Ensuring that we can not only keep what they tell us private, unless it is, of course, incredibly serious, but also giving them that confidence that they need to have in healthcare providers, as nurses, as nurse anesthetists. There are differences from adults in BMI, in blood pressure, heart rate, respirations. Be very familiar and knowledgeable about age-related vital signs. Testing their visual acuity, their teeth, their voice, other developmental findings. There are differences. You should be aware of these. You should know what is normal. If you are unaware, assess the growth chart. Ask further questions though. Were they premature? Were they Do they have an accident? Have they spent any extended time in a hospital? If somebody is quote unquote small for their age, ask appropriate and pertinent leading questions. Make sure you understand their full history. Now, that third part of health promotion and counseling. So, components of a health supervision visit for adolescents in that age group of preteen to teen, 11 to 18. There should be a discussion with their parents. Address not only parental concerns, but advice about supervision, encouraging that progressive, responsible decision making. Ask what schools, activities, social interactions the child attends and takes part of. What's their behavior and habits, maybe their mental health. Now, when it comes to discussion with the adolescents, focus on a few key areas: their social and emotional well-being, their mental health, their friends and family, their gender identity, their physical development, their self-concept. Are they getting adequate nutrition, exercise, TV, computer screen time? Are they partaking in drugs, alcohol, tobacco, e-cigarettes? How's their sleep schedule? Do they have questions about relationship and sexuality, dating, sexual activity, orientation? Have they had any type of sexual abuse? Their family functioning, relations with their parents and siblings, school activities, strengths and goals. Perform a careful examination. Note their growth parameter. Note their maturity. Perform proper screening tests when applicable for vision and hearing, blood pressure. Hematocrit. If you're getting labs, hematocrit is very valuable to assess in women and females. Their emotional health and risk factors. Immunizations. You should be very familiar with the adequate immunizations from the American Academy of Pediatrics. The promotion of healthy habits and behaviors is serious. Teaching them about injury and illness prevention, seatbelts, drunk driving, wearing helmets, sunscreen, weapons, nutrition, healthy meals and snacks, obesity prevention, oral health, seeing the dentist, brushing your teeth, physical activity and screen time. Adolescents should have confidence in opening up to healthcare providers about sexual behaviors, contraception needs and questions, high-risk behaviors, social achievements. These are all important components of a health supervision visit for adolescents, and positive interactions with parents can provide support and safety and help to increase responsibility from not only the adolescent's perspective, but also the parents. Now let's shift our focus into chapter 26, and let's look at pregnant women a little closer. Thinking about the anatomy and physiology of a pregnant woman, there are a number of changes, not only anatomically, but physiologically as well. From the growth of the infant to the change in nutrition that is necessary, the pressure that as the child grows, that is applied to not only the spinal canal, the dura, how there are changes in the internal organ structure and function, pressure on the bladder, pressure on the urethra. The abdominal organs are shifted up into the abdominal cavity, how the pelvic organs are shifted as well. The pregnant woman has a number of special needs and populations. The changes in ducts and glands, preparation for breastfeeding, the amount of nutrition that is needed, how pregnant women often have changes in their body and their functioning because the focus and shift is on the fetus. There are hormonal changes. Think about the estrogen and progesterone changes that are very common in the pregnant woman. It's very important that we, as anesthesia providers, keep this in mind. Think about the HCG changes, how those hormone imbalances create a not only shift in maybe the thought process, but how the hormonal changes have a direct impact on preparation for the arrival of the child. placental growth hormone, thyroid hormones, relaxin, erythropoietin, the delusional anemia that goes along with pregnancy. These are all things that we have to keep in mind that can have a direct impact on maybe our anesthetic plan and maybe how we care for these people. Thinking about other changes that women undergo to their skin, to their uterus, their sex organs, these are all things that we have to keep in mind whenever we're caring for these individuals. They may have questions. They may have certainly things that have become alarming to them. Now, from the male provider perspective, I'm much less likely to get any questions on this than some of my female colleagues. But if they do have a question, answering it not only appropriately is important, but also directing them to maybe someone that can give them a little bit more guidance. And also for my male providers and my female providers, making sure that whenever you are with someone of the opposite sex, it's very important to have someone else there with you. All right? Not only for your reputation, but also to make the patient feel comfortable. Oftentimes, we can, with our own experiences, underestimate the discomfort or maybe the frustrations that could come from being in a room with a stranger of the opposite sex. It's very important that we keep this in mind whenever we're going to assess patients. In that initial prenatal visit, while we're not the APRNs that are seeing them, we will eventually encounter these people whenever they come in, perhaps for surgery, for a non-obstetrical surgery. Hopefully not, but that happens very often. But we'll see them whenever it comes time for an epidural. But there's a confirmation of pregnancy, of the gestational age, what symptoms they're having, concerns, or their attitudes, their current, past, and family history, what risk factors they have, any genetic testing, any breastfeeding, contraception plans or questions. These are all very important things for providers to remember and keep in mind whenever you are caring and meeting with individuals who are pregnant. Now, components of that physical examination. We're going to begin with assessing their general health, their emotions, their nutrition, their coordination, inspection of their height, their weight, their BMI. These are important to consider, but also it's important for us to educate patients on what is a normal amount of weight to gain in pregnancy. What is normal expectations of being pregnant? Some cultures have a different view on the pregnant woman. Is she supposed to be active? Or do family members, maybe the mother-in-law, maybe other family members come and dote on her and don't let her do anything? Pregnant women should remain active. Pregnant women should be very active. Not only is that exercise healthy for them, but also for the fetus, making sure that they do not gain an excessive amount of weight, making sure that they do not lapse into a sedentary lifestyle. And we know that physical activity is very good and beneficial for mental health as well. We should inspect, percuss, auscultate, examine. Being able to measure fetal height and heart tones. Heart tones for us is important as anesthesia providers. That is something we will measure. At times, fetal height not necessarily, but it's important for us to recognize these things as part of the physical exam. What issues might a pregnant woman have? Hyperemesis is incredibly common. What can we do for them? How can we help them? Are we going down to start a difficult IV or going over to the OB-ED, which we now have at our hospital, and helping women who maybe are suffering from hyperemesis? What about women who are anemic, who maybe have to have a blood transfusion? That is something that is more and more common these days. It's important for us to ask about gestational hypertension, hyperreflexia, risk for preeclampsia. Are they dyspneic? Do they have edema? Varicose veins, dental problems, thyroid problems, any masses? Are they having any uterine contractions? These are all important things for us to address and at times answer questions on. When it comes to speculum examination, this is not something we're going to be doing, but it is important to note that in assessment, things like color, shape, closure, STDs, discharge, relaxation, color, rugae are important to examine. Like I said, this will not be something that we will be expected to do as anesthesia providers. Now, granted, I know CRNAs who have, I'm being serious when I say this, they've caught the fetus as they are going in for a multip to put it in an epidural, and suddenly the woman says, oh, I've got to push, and suddenly they're helping the woman back in bed and a baby is coming out. It's not something I really want to be a part of, but that is something that you may have to, at times, find yourself in a situation that you do not want to be in, but you have to be the provider in charge. There's this thing called Leopold maneuvers, okay? Notice that first, second, third, and fourth maneuver, how the assessment, all right, with your hands enables you to feel the fetus, ensuring proper positioning, understanding those anatomical landmarks. Like I said, not something I'm expecting anyone in here to be doing, but be aware that other APRNs, other providers may be doing this. When it comes to health promotion and counseling, talking and having frank discussions about nutrition, weight gain, exercise, and activity is incredibly important, along with substance use. At times, we may have to talk about intimate partner violence, making sure that patients are protected, that they have somebody there, that they are safe. Immunizations, supplementation, depression, pregnancy planning, laboratory, genetic testing. These are all important things to talk about, to discuss. And why it becomes such an important thing is because as a healthcare provider, we are oftentimes that first line of answering questions, okay? Even if it is not our area of expertise, we need to be able to point them in the right direction. I can't tell you how many times, because as anesthesia providers, especially as a competent CRNA, you're going to be asked and you're going to be told many times how you were just so easy to talk to, that you're so just wonderful, and they wish they could see you in the outpatient setting. And that's because as anesthesia providers, we don't have to see these patients back often. All right, we get to have good discussions with them because we're not always going to see them again. And that's okay. That's just fine. All right? But that good discussion, that good conversation, while nice to have, it is not necessary for us to continue lengthy conversations on areas that we are not an expert in. We can point them to the expert, but certainly we can share our knowledge whenever it is applicable. You need to be able to evaluate the prenatal laboratory screenings for Rh incompatibility, to recognizing syphilis, bacterium, hepatitis, HIV, iron deficiency, gestational diabetes, laboratory findings that put somebody at risk for preeclampsia, HELLP syndrome. These are all things that we need to be familiar with, that we need to be aware of as an anesthesia provider. These are things that you're going to be reviewing, especially if you work in the obstetrical department on a daily basis. All right, now let's shift our focus for this last little bit of this lecture to the older adult. When it comes to the older adult, we need to be aware of the anatomical and physiological changes. For instance, in vital signs, there's a rise in the systolic blood pressure. There's an increase in orthostatic hypotension. There are often benign, asymptomatic arrhythmias combined with syncope. There is a temperature dysregulation. Patients are more likely to be hypothermic. Patients will then manifest febrile symptoms for what we would consider a low or mid-grade fever. An example of this, and I have a family full of healthcare providers, my grandparents, my grandfather had been complaining on and off about what we all recognized, or at least thought of, was reflux symptoms. Say, okay, every now and then, when I get up or maybe after I eat, he would complain of maybe a little, he never really described it almost as pain, but just kind of an odd sensation in his chest. And at his last physical, they did an EKG, and he was an AFib. He had been having those changes. It's untelling how long he had been an AFib. And so having to go get him an echo and get him on some anticoagulation. My grandmother, she oftentimes is telling us that she has a fever and her temperature is 99, like 99.0. And because she's so used to, for years running, her normal temp, 97.0. So 2 degree fever, she's 99 degrees. Goodness, you put me in the sauna, I'm probably 99 degrees internal temperature by the time I get out. But these are just some of the changes that happen as we get older. What other changes do you anticipate seeing in the older adult? Skin changes. Unfortunately, our skin loses elasticity. We develop wrinkles. There's a loss of turgor. Maculas begin to develop. Eyes, the pupils become smaller. There are, of course, visual changes, cataracts. There's a decline in hearing. Our lymph nodes become less palpable. We can become kyphotic with our posture. These are just some of the changes that are unfortunately common in the aging adult. Now, when it comes to these changes, it's important that we recognize the importance of assessing these patients carefully, of keeping in mind that these are normal changes in the older adult. However, these are not oftentimes welcome changes. We need to be very supportive in assessing our elderly patients. We need to recognize that they may have hearing dysfunction. We may need to speak a little slower, a little louder, making sure that we give them the appropriate attention that they deserve. What are some other changes? Vascular changes, carotid bruits, a change in their cardiac output, murmurs, additional heart sounds. Their arteries become stiff and hardened. Their breasts develop lumps. A change in their fat distribution. They have less pain perception. There are sexual changes as well, decreased testicular size, erectile dysfunction, which is, unfortunately, I say unfortunately, we don't want to think about elderly people, especially, since we're younger. Many of us probably have parents and grandparents that are older. We really don't want to think about that. But sexual identity is incredibly important at any age as an adult, okay? Even elderly people have needs. And at times we're having to address this. At times we're having to have these difficult conversations. It's so important that whenever you're caring for elderly patients, when you're caring for older adults, that you remember that they were once young too. That these changes were not ones that they wished, that these are a natural part of life, that each and every one of us will have similar changes as well. Elderly patients often have incontinence. Men can have BPH, a loss of bone mass, osteoporosis, osteoarthritis, pain in the weather, pain in the cold, kyphosis, changes in posture, a decrease in their range of motion. Is this benign forgetfulness? Is this early or late onset dementia? Is this a benign tremor, or is this Parkinson's disease? Are they depressed, or is this dementia or delirium? These are important things for us to consider and keep in mind. I recently cared for an elderly patient with an SRNA, and we were talking about designing an anesthetic care plan on what would be the most appropriate thing. And I posed the question to them. I said, if this was your loved one, what would you want done? If this was your grandmother, if this was your grandfather, what would you want done? And we were going back and forth between Tiva and gas and other drugs. And she said, well, I would really want everything done to prevent post-operative cognitive dysfunction and decline. So then we are going to go out of our way. We are going to do a TIFA, even if it takes a little longer, because it's the better thing to do. So how do you take your approach to health history? Face the patient. Get on their level. Get on their eye level. Minimize noise. Pull the curtain. Make sure it's well lit. Pace for stamina. Include caregivers. Have an open-ended discussion. At times, you may allow for some reminiscing. Make sure you have an updated med list. Make sure that they have perhaps written instructions. Make sure that they understand what you're asking. Understand their health history. It's very important that we as anesthesia providers go out of our way to make patients feel comfortable. There's nothing more stressful than waiting to go into the operating room. What special concerns exist for the elderly? Well, certainly there are cultural disparities, functional and cognitive impairment, sadly. There are poor health maintenance and conditions that can result from chronic smoking, alcohol intake, nutrition deficits. Do elderly patients suffer from chronic pain? Do they have urinary incontinence? Is this predisposing them for a UTI? Is this what is leading to their fall? These are all important things for us to consider whenever we're talking to and assessing our elderly patients. Think about those cultural disparities for a moment. Do they have family here? Do they have caregivers? Are they having to pay people? Do they have the money to pay people? These are important things for us to consider. Who's with them? Is this an elderly couple who do not have any children who are caring for each other? Or is this somebody who has a number of family members there around them waiting to care for them? So many family members where they can have basically take shifts while their loved one is in the hospital, so they're never alone. Those patients are incredibly lucky and fortunate, but that's not always the case for individuals. They may be very lonely. Us being in there talking to them may be the most social interaction they get for the day. It may feel like it's hard to escape, but we may be the highlight of their day. Keep that in mind. Unfortunately, people who have chronically abused and used alcohol, there are some alcohol use disorder clues in older adults. Memory loss and cognitive impairment, depression and anxiety. Chronic alcohol usage leads to a number of problems. Elderly adults oftentimes are facing these. Do they have a neglect in their hygiene? Is there sleep disturbances we're aware of? Hypertension, hyperglycemia, hypoglycemia, seizures refractory to therapy, frequent falls, impaired balance, gastritis, esophagitis, difficulty maintaining a appropriate blood thinning regimen. Warfarin, for example, alcohol use can cause an inability to maintain adequate dosing. Use of other substances can lead to addiction, like sedatives, opioids, illicit drugs, nicotine. It is very hard to convince an elderly person who's abused alcohol their entire life that now is the time to stop. It's important for us to be respectful when we're assessing them, but also be firm in our findings. Ask them direct questions. It's probably not normal to have to give an elderly person 300 milligrams of propofol to induce them for a colonoscopy. That should be a red flag for us that they have a substance use disorder. Other issues in the elderly. Frailty is very common. Be aware of their advanced directives, their thoughts on palliative care. Do they have a durable power of attorney? Do they have a healthcare proxy? If they do, have a copy of this. Know who to contact. There is nothing more frustrating than a family who cannot agree on what to happen with their loved one. When it comes to physical examination and techniques of examination, this box 27.6 is great because this is a 10-minute geriatric screening looking at vision, hearing, mobility, urinary incontinence, nutrition, memory, depression, and physical disability. So for assessing vision, very specific measurements. Do you have difficulty driving, watching television, reading, doing any type of daily activities because of your eyesight? You can use a Snellen chart, and if it's a positive screen, assess them further. Use of an audioscope, set at a low decibel rating. Assess their frequency of hearing. Have them walk in front of you. Do they get short of breath? Can they stand up? If they're not able to complete a short 10 feet brisk walk, they're probably not able to have, or they don't have four meds. Ask about urinary incontinence, forgetfulness, waking up wet. Have you lost any urine? If it's yes to these questions, assess them for a UTI. Have they lost weight in the last 6 months without trying to do so? Weigh the patient. What's their BMI? What was it at their last appointment? 3-item recall. Ask them to remember a couple things and then assess it a minute later. Ask them about depression. Do you feel sad? For assessing physical ability or disability, ask them about strenuous activities, heavy work around the house. Who goes shopping for them? How are they getting groceries? Who's cooking? Do they go places? Who helps them bathe? Who helps them get dressed? Are they disheveled in front of you? Do you know they don't have caregivers or someone there? Sometimes these things are obvious, but we still need to assess them further. Identifying transient incontinence. Ironically, the acronym is DIAPPERS, DIAPPERS, delirium, infection, atrophic urethritis or vaginitis, pharmaceuticals, psychosocial disorders, excessive urinary output, restricted mobility, stool impaction. These are all ways to identify those transient incontinent episodes and important questions to ask. Now, one thing that, especially from an anesthetist perspective, it's very important, okay, that whenever we're caring for elderly patients, that we understand that our role as an anesthesia provider, even though incredibly short-lived, all right, is important. Do we leave our patients with a catheter after a spinal? You probably should. An in-and-out cath may not be enough, especially if you've given them a high amount or a large amount of fluid. Not putting in a catheter until the end of the case can cause stress incontinence, cause leaking, and they could be sitting in urine for an hour or two. Don't do that. Don't let a surgeon rush you. If the patient needs a Foley, make sure the nurse puts it in. When it comes to health promotion and counseling, performing these screening tests, while not something we're going to routinely be doing as anesthesia providers, it's important that we recommend them, that we recognize that it's important to assess someone's activity, that we recognize their safety is a priority. Are they getting their immunizations? Are they depressed? Do they have delirium? Do they have dementia? Are they being mistreated? Are they being treated well? These are very important things for us to ask and consider whenever we see our elderly patients. Some household safety tips for older adults. Now these should be somewhat common sense to us, but this is a good refresher. Having bright lights, curtains, shades, ensuring that they are able to see. Handrails, pathways should be well lit. Remove any items that could cause tripping or obstacles. Elderly patients, of course, can oftentimes hoard, clearing those pathways. Remove any small throw rugs or secure them with double-sided tape. Wear shoes both inside and outside. Avoid bare feet or slippers, especially if somebody has neuropathy. Store your medications safely. Make sure that you are keeping track of whenever you take your medications. Keep them in a cabinet that is easy to reach without using a step stool. Having grab bars, non-slip mats, life alert bracelets, the ability to call someone in an emergency. Repair any faulty plugs. Install smoke alarms. Have a plan to escape a fire. Secure all fire alarms. Have a way to get in contact with your emergency contact. for elderly adults, it's important that they get a flu vaccination, that they are up to date on their tetanus and diphtheria and pertussis vaccination. Have they had a Tdap booster? Have they had a varicella vaccination? A zoster vaccination is incredibly important, especially if they're over 50 years of age. Pneumococcal vaccinations to help prevent pneumonia is incredibly important. And finally, cancer screening in the elderly is crucial. Breast cancer in women, mammograms every 2 years for women aged 50 to 74. Cervical cancer screenings. There's a recommendation against routine screening for women over the age of 65 if they've had adequate recent screenings and normal pap smears. Oftentimes they have not. Colorectal cancer screening. Now it's more important to get colonoscopies at earlier, 45 years of age. Okay? It's very important. Getting a colonoscopy is one of the best ways to maintain your health. For men, prostate cancer screening, your prostate-specific antigen, assessing your prostate. Lung cancer screening for those who've had an extensive smoking history or been exposed to secondhand smoke. Skin cancer screening as well. It's important for patients to see a dermatologist. Keeping these things in mind as we approach and assess elderly patients is incredibly important, because our practice as anesthesia providers, we are APRNs. We are able to get people to other providers that they need to see. We are able to give them recommendations that can be life-saving. Do not underestimate the power you have as an anesthesia provider and what you can do for your patients.